Hello everyone. Today we're going to see drugs for diabetes part 1. So part 1 is all about the types of diabetes and oral hypoglycemic agents. In part 2 we will deal with the insulin or the injectable preparations that could be used for diabetes mellitus. Okay. So there are different types of diabetes. Before going into the types, we need to see what exactly is the problem. Okay, what kind of problem would you experience with diabetes? So basically, there is an organ, pancreas. Pancreas is a very important organ for glucose homeostasis. Glucose homeostasis means the balance of glucose or the state of glucose in the body, the production of glucose, and also for the metabolism of glucose or the utilization of glucose, and also for glucose uptake into the cells, we need insulin. And insulin is also produced in the pancreas. So pancreas is a very important hormone regulating the amounts of glucose in the body. In the pancreas, we have certain types of cells called cells in the islets of Langerhans. Islets of Langerhans basically means they are endocrine tissues. So endocrine tissue means they secrete or they release hormones to the bloodstream. Okay, so pancreas, the cells in the islets of Langerhans, inside the pancreas, those are the locations. Here, the islets of Langerhans, we can see regularly shaped patches of endocrine tissue, which are full of different types of cells. Primarily, there is one specific type of cell called alpha cells. And alpha cell is responsible for the production of glucagon. Then we have beta cells. Beta cells are responsible for the production of insulin. And we have delta cells for the production of somatostatin. And another type of cell, which is not given in most of the textbooks, cells. In the F cells, we produce pancreatic polypeptide. Basically, all these hormones play a major role in the homeostasis of what? Glucose. Okay. And so you might know about this. What is diabetes mellitus? Diabetes mellitus means hypoglycemia, increased or elevated levels of glucose in the blood. And here we're going to study what are the different types of diabetes and what is the reason for increased levels of glucose in the blood and also the complications. Right? So complications, I'm just going to give you an overview of the complication because this is not the pathophysiology. We are not going to study about the pharmacotherapeutics of glucose. We are just focusing on the drugs for diabetes today. So complications of diabetes mellitus are acute complications and chronic complications. Acute complications are actually divided into two, or acute emergencies can be divided into two. One is hypoglycemic emergency, hypoglycemia. Okay, this is a problem because hypoglycemia might cause or might lead to hypoglycemic coma or death. And the next emergency is hypoglycemia. That's a hypoglycemic emergency. And the next emergency is due to elevated levels of glucose, maybe more than 500 mg per dl or 600 mg per dl, or twofold increase or threefold increase of glucose levels. Hyperglycemic emergencies. Acute hyperglycemic emergencies are two. One is diabetic ketoacidosis, mostly seen in type 1 diabetes mellitus patients, and HHS. So this is hyperosmolar hyperglycemic state. This is probably most seen in type 2 diabetes mellitus patients. These are the acute emergencies which need prompt treatment. And the chronic complications of diabetes are divided again into two groups, microvascular complications and macrovascular complications. Microvascular complications are three: diabetic retinopathy, when diabetes affects your eyes, affects your vision, retinal damage, optic nerve damage, nephropathy, when it affects your kidney, and when it affects your nerves, that's going to be peripheral neuropathy or neuropathy. So all these three complications are microvascular complications: retinopathy, nephropathy, and neuropathy. And there could be sometimes macrovascular complications. such as heart failure. Now, so that was just an overview, not everything in detail. What are the different types of diabetes? Type 1. Type 1, the specifics of type 1 are, it usually occurs during childhood or puberty, mostly before the age of 30. But some latent forms of type 1 can also occur. Okay, so I won't tell that it will not occur after 30. It might occur after 30. So that is the latent form. But usually type 1 diabetes mellitus occurs during childhood or puberty. And the prevalence means how many percentage of the people or how many people have type 1 diabetes. Among all the diabetes patients, only 5 to 10% of people having type 1 diabetes mellitus, and other 90 to 95% people will have type 2 diabetes. So prevalence is only 5 to 10%. And what about the genetic predisposition? Here we do not have a strong genetic predisposition. We have a moderate genetic predisposition. Predisposition means if your father or mother has this problem, or if any one of your family members and immediate family members have this problem, what is your susceptibility? What is the range of predisposition? So that's what's called genetic predisposition. So here we have moderate genetic predisposition. Now, most of the type 1 diabetes mellitus patients are undernourished or they are lean. So here what's going to happen is autoimmune destruction of beta cells. In type 1, this is because of autoimmune destruction of beta cells. Okay, why? So our body, when it gets exposed to certain environmental factors, maybe chemicals or toxins or any types of viruses sometimes. So when our body gets exposed to these environmental toxins or factors, what's going to happen next? Usually we have immune response in our body because that's a foreign material, so our body should have an immune response against it. But in this case, if you have chances of developing type 1 diabetes mellitus, your body's immune response will be inappropriate. And that inappropriate immune response will cause destruction of your own cells, especially the beta cells. So that's going to cause beta cell destruction. Beta cells are responsible for the production of insulin deficiency. And type 1 diabetes mellitus patients or people have absolute insulin deficiency. So insulin must be given exogenously for these patients. Okay, this is absolute insulin deficiency. Now what about type 2? Type 2 commonly occurs over the age of 35, and these people are mostly not undernourished or malnourished. They're usually obese, especially they have more adipose tissue accumulation, a greater waist circumference than normal people, a pot belly, etc. And the prevalence is around 90 to 95%. And here we can see a strong genetic predisposition rather than moderate or low genetic predisposition. What about insulin? So here we do not have beta cells destruction initially. Initially, the problem with these people, the type 2 diabetes mellitus people, is insulin is present, but this insulin cannot be utilized. Insulin is responsible for the peripheral uptake of glucose, meaning glucose in the plasma must be taken up into different tissues, adipose tissues, muscles, liver. So this process must happen after food intake. Okay, so this uptake is carried out, this particular uptake is carried out by the insulin. So when these cells, adipose tissue cells or muscle cells or liver cells or any other tissues that can take up insulin, because insulin is responsible for glucose is responsible for the production of energy, for the production of ATP inside cell, and insulin is a pushing factor, push glucose into this cells, and this means the peripheral uptake of glucose. So if you have decreased sensitivity towards insulin, that's going to cause increased plasma glucose levels, thereby decreased uptake into the different types of tissues. So primarily in type 2 diabetes mellitus, you can see decreased insulin sensitivity. But insulin is there, and your beta cells are going to produce more and more and more insulin in the initial phases, and you'll get hyperinsulinemia sometimes. Remember, insulin is not the problem in the beginning. The problem is the functioning of the insulin. Insulin would be there, but insulin is not functioning well. Okay? Now, and after so many years, maybe 10 to 20 years, the beta cells, due to much strain, due to much pressure on the beta cells are going to be damaged, and that will also cause insulin deficiency. So type 2 basically means decreased insulin sensitivity and relative, not absolute insulin deficiency, but there will be relative insulin deficiency. Somewhat, it's a bit, okay, insulin deficiency can also be seen, but not absolute. Your bodies can still make insulin, but cannot utilize insulin. Now, the next type is gestational diabetes mellitus. So the first onset of diabetes during pregnancy, that is gestational diabetes. Screening for gestational diabetes must be done for all pregnant women between 24 and 28 weeks of gestation. What are the complications of gestational hyperglycemia or gestational diabetes mellitus? Macrosomia, babies with birth weight of more than 4 kilograms or 4.5 kilograms, that is macrosomia. Preeclampsia, hypertensive states or proteinuria, sometimes eclampsia and seizures, shoulder dislocation of the babies when their head is stuck at the vaginal canal. These are the complications. And some people will have diabetes, not actually diabetes, but hyperglycemia or changes in the glucose levels in the plasma during the menstrual phase, that is catamenial hypoglycemia. Okay. Now, diagnosis is based on the basis of clinical manifestations. So what are the basic 3 manifestations? Symptoms: polyuria, polydipsia, and polyphagia. Increased urination, polyuria, increased thirst, and increased hunger, plus poor wound healing, tiredness, fatigue, etc. Now, the blood sugar levels, you need to know the values of normal blood sugar, and the HbA1c. So HbA1c is the rate of formation of glycosylated hemoglobin. If the rate of formation of glycosylated hemoglobin, it's actually proportional to the amount of blood glucose you have. So when you check the HbA1c, you get how much hemoglobin is bound to glucose. So HbA1c is assessed in percentage. So that shows you an idea of the glucose levels in your body over the previous 3 months. HbA1c, rate of formation of A1c, is that's proportional to the average blood glucose concentration over the previous 3 months. If it is more than 6.5, that means you have diabetes. That's in percentage. Okay. Now, FPS is fasting blood sugar levels, must be measured after 8 hours of fasting. If it's more than 126 mg per dl, that shows diabetes mellitus. If PPBS is postprandial blood sugar levels, or PPBG, postprandial blood glucose levels. So this one is to be taken 2 hours after the breakfast or after food. Now, if it's more than 200 mg per dl, that's because of diabetes. You can diagnose the patient with diabetes. Now, HbA1c, 6.5%. If it's more than 6.5% or somewhere equal to 6.5%, then that shows kind of you have diabetes mellitus. It's slightly, you have diabetes and it's slightly high. Now, borderline diabetes mellitus means the person is predisposed to have diabetes mellitus, so there is a risk, and you need to tell the patient to follow a certain diet or follow certain exercises in order to reduce the risk of becoming a diabetic patient. Fasting blood glucose here is 100 to 125 mg per dl. PBBS 140 to 199 mg per dl, A1C 5.7 to 6.4 percentage. Now we're going to directly see the drugs. Today we're going to deal with OHAs only, oral hypoglycemic agents. First one, or the initial therapy for diabetes, is metformin. Metformin is a biguanide. This is the class biguanide. And there is another biguanide, which was banned due to certain reasons, especially lactic acidosis. That one's name is pefenformin, but we don't use fenformin anymore because of lactic acidosis. Now, what's the mechanism of metformin? The main mechanism is it is an insulin sensitizer, means it increases the sensitivity of insulin to the tissues. That would increase glucose uptake into the adipose tissue, into the liver, into the muscles. So basically, increases glucose uptake by increasing insulin sensitivity. Plus, it has an additional mechanism. It reduces glucose production in the liver, hepatic gluconeogenesis, decreased hepatic gluconeogenesis. And biguanides, there is one advantage: moderate weight loss. Not too severe, but moderate weight loss. There is no weight gain with biguanide. Now, this is the initial drug of choice. So if you ever get a question like this, a 35-year-old patient or a 40-year-old patient comes to the physician with so and so problems, polyuria, polyphagia, polydipsia, and the person's value is slightly different from the normal values. What can you give to the patient as an initial therapy? Always the initial choice for type 2 diabetes mellitus is metformin. Okay, remember this. Now, the drug is not bound to serum proteins, not get metabolized, but the excretion happens through kidney. You need to adjust the doses in renal impairment, otherwise it would cause lactic acidosis. What are the certain problems that you can experience with metformin? First one is GI problems or GI distress, probably during the initial days. And so when we give metformin, we give a lower dose, lowest possible dose, maybe 500 milligram once a day. Then we slightly increase the dose when the patient can tolerate this. So this is called upward titration. This is because of a certain problem that this metformin can initially cause GI distress that might cause non-compliance to the drug. So GI distress is a problem. You need to counsel patient. Okay, it can happen, but it may resolve over a period of time. Maybe it may only happen for very few days. Now, the next problem is in renal dysfunction. If you give a metformin, that's going to cause lactic acidosis. Metformin doesn't cause renal impairment, okay? But if you are giving metformin to a patient with renal impairment, that may cause accumulation of lactate ions, which would cause metabolic acidosis or lactic acidosis, okay? So this is an important question for some exams. Metformin's adverse effects, lactic acidosis, or the adverse effect of biguanides, or why metformin was banned. Now, the next problem is do not give metformin if the patient has to undergo a procedure after administering IV radiographic contrast media, because metformin can interact with IV radiographic contrast media that we usually give for MRI scans or CT scans. So stop metformin 24 hours prior to IV radiographic contrast media and 48 hours after radiographic contrast media to avoid these interferences and interaction. Now, another problem is it should not be given to patients with liver dysfunction or cardiovascular dysfunction, because metformin accumulation can happen in cardiovascular dysfunction. Metformin accumulation can happen in hepatic dysfunction, which might cause lactic acidosis. So if the patient has severe heart failure, severe cardiovascular problems, or severe liver dysfunction, or to alcoholics, never ever give metformin. And metformin can also cause vitamin B12 deficiency after a period of 1 year intake. So probably that because of the impairment of vitamin B12 absorption, you need to give vitamin B12 supplements with metformin to avoid the complications of vitamin B12 deficiency. What are the different complications of vitamin B12 deficiency? Anemia, megaloblastic anemia, vitamin B12 or folic acid deficiency, and also peripheral neuropathy. And also peripheral neuropathy is a complication of diabetes mellitus. Now, the next category of important drug is sulfonylureas. Sulfonylureas are not insulin sensitizers. Instead, they are insulin secretagogues. They increase the secretion of insulin from the pancreatic beta cells. That's the meaning. Insulin secretagogues. I forgot to tell you one more thing. Metformin can also be used for PCOS, polycystic ovarian syndrome, and infertility treatment. Probably due to insulin resistance, PCOS. Now, sulfonylureas are insulin secretagogues. This is the mechanism of action. They block. There are first generation and second generation drugs. We mostly use second generation drug nowadays. We stopped using first generation drugs due to the heightened risk of side effects or the adverse effects. Now, they block ATP sensitive potassium channels, and that causes accumulation of potassium inside the cell, which in turn causes accumulation of calcium and more calcium from sarcoplasmic reticulum, so calcium influx and more release of calcium from the sarcoplasmic reticulum. So increase in calcium means depolarization, okay? And that will cause exocytosis of insulin from the stored vesicles, from the beta cells. So this is an insulin secretagogue. This is the main mechanism of action. And the additional mechanism of action is this may sometimes decrease hepatic gluconeogenesis and may increase peripheral insulin sensitivity. So these drugs, there are two categories of drugs, first generation and second generation. These are some of the examples. First generation, chlorpropamide, furosemide, tolbutamide, etc. You might know about the second generation agents because those are the commonly prescribing drugs nowadays. Glyburide, glimepiride, glibenclamide, glipizide, glucoside, etc. Now, talking about the pharmacokinetics of these drugs, they bind to serum proteins. Metabolism happens inside the liver, excretion through urine and also through feces. And the duration of action is actually prolonged 12 to 24 hours. Now, what are the adverse effects? So mainly there are two adverse effects. Insulin is an anabolic hormone. So whichever drug you give that increases the insulin secretion, which will cause weight gain. Weight gain is a problem, and another problem is hypoglycemia because of insulin secretion. These are the two, and hyperinsulinemia also. These are the two main problems, and this is an emergency, hypoglycemic emergency. Now, the longest duration of action is with the glibenclamide, so glibenclamide has more chances of causing hypoglycemia. And two drugs can be safely given in renal impairment, glimepiride, sometimes we have to decrease the doses according to different guidelines, and glipizide. Now, the next class of insulin secretagogues are called glinides. So they are also insulin, not sensitizers, secretagogues, just like sulfonylureas, but not as potent as sulfonylureas. They are there, but fast acting. Glinides examples are brepaglinide and nataglinide. Okay, rapid onset of action, short duration of action, and they have to be taken before food. These drugs have to be taken just before food because they are postprandial glucose regulators. Postprandial glucose regulators means they regulate the glucose after eating, after food intake. Now, pharmacokinetics. This has to be given prior to a meal. Metabolism happens through CYP3A4 enzyme and excretion is through bile. Adverse effects are very much similar to sulfonylureas, hypoglycemia, hyperinsulinemia, and weight gain, but the incidence of weight gain or the incidence of hypoglycemia is not as severe as sulfonylureas. And drug interaction can happen with gemfibrosol because gemfibrosol is a IPF450 inhibitor. So if you ever give gemfibrosol plus this drug together, that would increase the plasma concentration of tetraglinide, reproglinide, which would cause hypoglycemia. And some drugs can also interact with sulfonylureas. For example, some drugs may decrease the action of sulfonylureas. So drugs reducing the effects of sulfonylureas are the following drugs. Reducing the effects means these drugs can cause hyperglycemia. Atypical antipsychotics, corticosteroids, diuretics, niacin, phenylthiazine, sympathomimetics, etc. All these drugs can increase blood glucose level, hyperglycemia. And the following drugs potentiating the effects of sulfonylureas. Potentiating the effects of sulfonylurea basically means what? Causing hypoglycemia, as all antifungals, beta blockers, chloramphenicol, monoamine oxidase inhibitors, clarithromycin, probenoids, different salicylates, and sulfonamides. And dysglycemia can happen with fluoroquinolones. Dysglycemia means fluoroquinolones can either increase or decrease sugar levels, especially in diabetes mellitus patients. Now, the next category of drug is thiazolidinediones. They are insulin sensitizers. These ones have a unique mechanism of action. They activate a particular type of receptor called PPAR gamma. Activate a receptor, which is a nuclear hormone receptor. The receptor's name is PPAR gamma. The expanded form is peroxisome proliferator activated receptor gamma. This receptor is responsible for glucose and lipid metabolism. So agonist of pioglitazone and rosiglitazone, those are the two drugs coming under this category. Pioglitazone and rosiglitazone. Agonist of peroxisome proliferator activated receptor gamma regulates genes involved in lipid and glucose metabolism. So that is the main mechanism which increases peripheral insulin sensitivity. Plus, the additional mechanism is it decreases hepatic gluconeogenesis, decreases hepatic glucose production, that is gluconeogenesis, the new glucose molecule formation. Activation of PPAR gamma regulates transcription of several genes involved in increased insulin sensitivity in adipose tissues, liver, and skeletal muscles. Now, pioglitazone is not a first-line drug. The first-line drug is metformin. This could be a second-line or third-line drug. And rosiglitazone, the use of rosiglitazone is associated with certain concerns. The concerns, especially the cardiovascular adverse effects concern. So probably people or the doctors, they wouldn't recommend rosiglitazone as a second or third line. Instead, they give pioglitazone. Pharmacokinetic parameters, only the important pharmacokinetic parameters. These drugs are extensively bound to albumin, so the free fraction is less. Extensive metabolism happens in the liver through CYP450 enzymes, and some metabolites of pioglitazone are active because they have activity. Excretion is through bile feces, so no dose adjustment is required in renal failure. And what are the different adverse effects of thiazolidinediones? Liver toxicity is one adverse effect. So before starting this drug, baseline LFT must be monitored, and periodic monitoring is also required, especially if the patient is tired, if the patient shows any clinical manifestations of liver toxicity. Anyway, the patient has to come for follow-up every month if they are diabetic. So the periodic monitoring is possible when doctors assess the patient's fires. Weight gain is another problem, especially because of an increase in subcutaneous fat and also because of edema. And edema is a problem, weight gain is a problem. So these drugs should be avoided in severe heart failure. Another risk is fracture risk because of osteopenia. Osteopenia is decreased bone mineral density, or osteoporosis can also happen with this drug, and there is a risk of bladder cancer. So in some countries, in some areas, this drug is actually kind of banned or not utilized commonly because of the risk of bladder cancer. And rosiglitazone has a boxed warning. This is a boxed warning. Increased risk of myocardial infarction and angina. Next class of drugs are alpha-glucosidase inhibitors. These drugs are reversible inhibitors of alpha-glucosidase enzyme. Alpha-glucosidase enzyme is present in the intestinal brush border. Right? So alpha-glucosidase enzyme is meant for the breakdown of carbohydrate into simple sugars. When you inhibit this particular enzyme, the breakdown of carbohydrates wouldn't happen fast. Okay, which or we can say it slows down the breakdown of carbohydrates. That's how we're gonna reduce the sudden flex or a sudden increase in glucose levels in a blood. So they're not first line or second line, but they can be given as adjuvant. This should be taken at the start of the meal. Some drugs can be chewed, okay, and it has to be taken with three main meals: morning, lunch, breakfast, lunch, and dinner. They delay carbohydrate absorption or the digestion. And I'll give you the drug names now: acarbose, miglitol, voglibros, etc. Three times a day with meal or with the first bite of the meal. That's a counseling point. Uh, Monotherapy with alpha-glucosidase inhibitors will not cause hypoglycemia. But if you take it with insulin or sulfonylureas, the main problem with insulin secretagogues are hypoglycemia. So monotherapy is not sufficient or not enough to cause hypoglycemia. But therapy with insulin plus alpha-glucosidase inhibitors or sulfonylureas plus alpha-glucosidase inhibitors may cause hypoglycemia. So if you ever consider this, or when you counsel the patients how to treat the hypoglycemia, tell them to take glucose, not sucrose, because sucrose will be converted to glucose by an enzyme sucrase. Sucrase will also be inhibited by alpha-glucosidase inhibitors. So do not take sucrose; that will not be effective when the patient on this trial. Just help them to take glucose instead of sucrose if they ever feel hypoglycemia. What are the pharmacokinetic parameters or the properties? Poor absorption from the gastrointestinal tract. We need action in the gastrointestinal tract. Metabolism happens through intestinal bacteria and excretion through the kidney. What are the adverse effects? The main adverse effects are GI related adverse effects: nausea, vomiting, diarrhea, bloating, farting, flatulence, etc. And it is contraindicated if the patient has inflammatory bowel disease or intestinal obstruction or colonic ulceration, because all these problems will be exacerbated by the drug because of bloating, flatulence, and the indigestion of carbohydrates. The next class of drug is DPP-4 inhibitors. They are also called gliptins. The expanded form of DPP is dipeptidyl peptidase 4. Now, basically, the dipeptidyl peptidase 4 enzyme is responsible for the conversion of incretin hormones. There are two incretin hormones in our body: GIP and GLP-1. So, okay, imagine this. There are certain hormones in our body, GIP and GLP-1, which will be released in response to oral glucose. Your GI tracts, the intestine, will produce these things: GIP, gastric inhibitory peptide, and glucagon-like peptide 1 in response to oral glucose or glucose ingestion, not injection, ingestion. Now, incretin hormones will be inactive using, or will get inactive using dipeptidyl peptidase 4 enzyme. When you use the inhibitors, DPP-4 inhibitors, they're going to increase the amounts of GIP and GLP-1. What is the function, or why do we have to increase GIP and GLP? The functions of incretin are many, but not limited to. The first one is glucose-dependent insulin secretion. This is one function. Second one, inhibiting, it inhibits, DPP-4 inhibitor inhibits inappropriate glucagon secretion Third one, beta cell proliferation. Fourth one, increase satiety. Satiety means a feeling of fullness. Okay, a feeling of satisfaction after eating food. You don't want to eat many more food. These are the functions of incretins, GLP-1 and GIP. So when you inhibit DPP-4 enzyme, incretins will be more. The metabolism or the inactivation of incretin doesn't happen. Now, so DPP-4 inhibitors will have these two mechanisms. They inhibit glucose-dependent insulin secretion and they inhibit inappropriate glucagon secretion. They are weight neutral. Okay, they're not going to cause weight loss or weight gain. They're weight neutral and they're not effective in fullness or satiety. The drugs, the oral drugs. Now, what are the drug names? Sitagliptin, alogliptin, linagliptin, saxagliptin. These are the different drug names. They are called gliptins because of the name, because of the suffix in their names. Pharmacokinetic properties. These drugs are going to be well absorbed from the gastrointestinal tract. Alogliptin and sitagliptin are excreted through urine. Saxagliptin will also form an active metabolite with the help of 3A45 CYP. I'm sorry, 3A45 enzyme. Linagliptin is excreted through enterohepatic system. So this is an exam question for some exams. Sorry. Linagliptin, no dose adjustment is required in renal failure. Renal impairment. Renal impaired patient, this is a safe medication. Adverse effects are minimal. The most common or the usual side effects are nasopharyngitis and headache. Pancreatitis is a rare problem. Musculoskeletal pain, joint pain can happen, and it also increases the risk of heart failure hospitalization. So try to give it cautiously in heart failure patients. Next class of drug is sodium glucose cotransporter 2 inhibitor. That is SGLT2 inhibitors. Sodium glucose cotransporter inhibitors. So here the mechanism is these drugs will prevent the reabsorption of glucose and sodium, the filtered glucose and sodium in the renal tubules. Inhibit the reabsorption of glucose back into the blood and sodium back into the blood, which in turn increases the excretion of sodium and glucose. More excretion of glucose will reduce the amount of glucose, plasma glucose. Now that's a mechanism. So here canagliflozin must be taken before food. All other drugs can be taken after food. SGLT2 inhibitors can also be called as gliflozins. Canagliflozin, empagliflozin, bremogliflozin, dapagliflozin, H2gliflozin. There are so too many drugs. And they have to be given OD. Okay, these drugs have to be given OD. Avoided in renal dysfunction. But the side effects are very, very important. And this is a counseling point you need to tell the patient. Because of glucose excretion, these drugs may cause vulvovaginal candidiasis in females, UTI in both males and females, Fournier's gangrene, gangrene of the scrotum penis in males, Fournier's gangrene. It might exacerbate diabetic ketoacidosis, and it also causes hypertension because of the excretion of sodium. Now, these drugs are very good for patients with diabetes mellitus plus heart failure with reduced ejection fraction. These are the choice of drugs. Okay, diabetes mellitus of a patient comes with these two problems because they decrease waist circumference, they cause weight loss, but the patients must take a lot of water to avoid UTI or the vulvovaginal candidiasis. You need to counsel patients on these points. And other agents, like the miscellaneous agents, are some areas people use bromocriptine. Bromocriptine is a dopamine agonist, which will regulate the dopamine levels, which might probably cause a restriction in glucose production that maintains the balance of glucose homeostasis. And in some areas, I mean, in American Diabetes Associations, PDF, they say all these things. Guidelines, they say all these things. Bromocriptine, cholesterol can be used as miscellaneous agents. The exact mechanism of action is not known, but they are not first line or second line. They can only be used as adjunct to regulate the circadian rhythm or to increase the excretion of glucose. So all these drugs are the main causes of oral hypoglycemic agents. You need to go through this, the types, and you need to by heart the values, diagnosis, the complications, plus the oral hypoglycemic agents. Anything can be asked because diabetes mellitus is a chronic disease. And worldwide, people have this problem. So you have to counsel patients on everything, on mechanism of action. I also advise patients on the adverse effects, all the counseling points, how many times they have to take these drugs, especially before food or after food or with food. All these things must be given to them. So read any pharmacology textbook, any good pharmacology textbook. I opt this one, Lippincott's edition, Lippincott Illustrated Reviews of Pharmacology, the South Asian edition, because the information or the content in the international edition is very less. If you're a good pharmacologist, international edition is enough. But if you need more details on this, you must use Lippincott's Illustrated Reviews of Pharmacology, or else you can use Katz and Trova Pharmacology textbook. Now, the next thing is you can or Satoska. And so the first part is finished. The next part is about IV agents. IV agents are the parenteral administration. We have IV regular insulin and some other subcutaneous or IM agents. So anyway, the injectable preparations will be studied in a different class. Thank you.